This podcast is a production of Open Pediatrics, an open access online community of healthcare professionals sharing best practices from around the world. Visit openpediatrics.org for more.
Welcome to the World Shared Practice Forum on Open Pediatrics. I'm Jeff Burns from Boston Children's Hospital, and we are very pleased to have with us today Dr. Janet Kelly-Geyer and Dr. Luregn Schlapbach from the Department of Intensive Care and Neonatology and Children's Research Center, University Children's Hospital Zurich, and the University of Zurich in Zurich, Switzerland. Janet and Luregn, as you know, we've invited you on to the Open Pediatrics podcast because of your publication in the February 2026 issue of Pediatric Critical Care Medicine entitled The Airway Breathing Circulation Plan Risk Options, or ABC Pro, handover tool in the PICU, a retrospective evaluation of pre versus post implementation and occurrence rate of cardiac arrests from 2020 to 2023. And I wonder if I could begin by asking, why did you do this study? What was your objective in developing the study? What questions were you trying to answer?
Thank you so much, Jeff, for having us here on Open Pediatrics. The study actually started with what I think is natural to most PICUs, is that you wonder actually how can you improve the quality of care in your unit. It was really triggered by a number of sentinel events. So we reviewed cardiac arrests that occurred in the ICU, and in the discussion we found some patterns which made us think that some of these arrests were actually potentially preventable. And specifically, the pattern that turned up was that some people then actually said is, actually when we brought in the patient to the ICU, for example, we thought that was a risk, but somehow a few hours down the track, that notion had been lost. And that in particular, some of the people spending most times at the bedside, in particular the nurses and the residents, were not always aware of some of the risk assessment and planning that actually had been discussed, for example, during daytime. And not all of that information made it down to the night team, right? And we realized that there was a bit of a discrepancy between senior team members sometimes thinking, this is not that surprising. We could have prevented this or we could have foreseen this, and other team members that were not fully aware of this. And so we thought, okay, we all know how important handovers are in practice. We know that handovers is something which we do, many, many times a day in every ICU, right? But how much do we really know about the best practice to do such? And if you look back in 2007, so almost 20 years ago, was what I think is one of the landmark papers in our field on this topic. Was published by Catchpole and others, which looked at handover, the pit stop type handover informed by Formula 1 in a cardiac ICU. And I think this paper really changed how most units do handovers. But if you look at their outcome, they really focused on the information transfer. Their main outcome that they looked at were omissions or errors in the handover. And this was essentially defined as factual information. And as well, if you look at other handover literature, such as, the IPAS paper from, Starmer, published in, over 10 years ago, which a lot of these papers, they show a reduction in medical errors based on correct handover information. But the information in scope here is usually essentially historic or retrospective information, right? So the team that has been working the last shift gives the next team or the next discipline the information on what has happened before, right? But is this really all we need? Because we actually, in ICU, how we work is we want to predict what's going to happen in the next 12 hours. And we want to adapt our practice and our interventions to what we think will happen, not to what has happened, right? And so I think the uniqueness of ICU is a very dynamic and time-critical, discipline is that in our daily work, we do need historic information, but we operate more on essentially continuous prediction and forecasting, right? And this is what we thought, okay, if we want to be a good ICU, the basis is good information transfer of essentially historic information, but we need to then shape this into being ready to what may happen in the future. How can we recognize patterns and deviations of these patterns to be really ready to respond effectively to patient trajectories before arrests happen, right? And so this is essentially the departure point that we said, informed by these sentinel events. How can we move from a more reactive historic focus towards a more proactive approach? And how can we do this in a way that it benefits as well those patients those team members that spend most time at the bedside, including nurses and the residents?
You can't be a practicing intensivist, or for that matter, work in a hospital anywhere around the world to realize how important this issue is and how much it resonates with all of us. And so absolutely important area to study. But could you tell us more about the ABC Pro handover and risk assessment tool? What does it mean, and how did you implement it?
So we're in a unit which has well-established structural policies and handover policies. We've used the ABC, so airway, breathing, circulation, disability, exposure, etc., handover tool for many years very successfully. So the team is used to a structured handover of information. We perform handover 3 times a day at the bedside with a multidisciplinary team, so all of the involved doctors and nurses plus the charge nurse of the unit. And what we really wanted to do was to combine our handover of historical information with the 4 key needs that we saw for what we need to anticipate. So, a risk stratification to try and help improve both interprofessional and also for senior to junior medical staff to make people aware of specific patient risks. So, specifically, which patients are at risk, which patient am I as the attending worried about, some anticipatory preparedness to give the more junior members of the team the knowledge to treat the problem should it occur, things that we're worried about. So, their management options for a problem that might occur, and also to give the team a shared mental model of management and risk. So, that would also enable an interdisciplinary or interprofessional plus up and down the hierarchy speak up if someone doesn't agree. And so the way we've structured it is to have an ABC handover as usual. And then we have the pro component, which is the new part which we added on, which is the plan for the patient for the following 12 hours, the risks. So, how do we see the risk? And this we categorize very simply. So, red for high risk patients, orange for medium risk patients, and green for low risk patients, and also the list of the specific risks that we're worried about for a particular patient. And then the O, the options, the management options for what you might do if these specific risks occur. So this will be formulated at the bedside by usually the resident doctor, and anyone present at the handover, which happens 3 times a day, and obviously at the admission of a patient, can contribute to that and say, hey, I see it differently. I'm concerned about this risk, or I think this patient is high risk or low risk. And that has the major advantage that it can stimulate discussion about the risk of a patient. And it also has the ability of breaking down hierarchical barriers because everyone knows they're encouraged to contribute at this point in time. So an example would be this is a 6-month-old boy. He's day 3 on the ICU, intubated for bronchiolitis. Then you would go through the airway, breathing, circulation, disability, then formulate a plan. So in the next hours, he should be extubated. The risks due to multiple intubation attempts, the patient is at risk of post-extubation upper airway obstruction, and then suggest possible options. So for upper airway obstruction, the adrenaline nebulizer has been prepared. In the case of failed extubation, a video laryngoscope and endotracheal tube plus a smaller size tube have been prepared. So that's the structure of our new tool. And how did we do it? So the resident nurse and consultant can contribute at any time to this risk assessment and the formulation of the plan. And the advantage of this is it prompts discussion on the why, on to improve understanding, and it also prompts the development of a learning team, which is, as you know, is a feature of a high reliability organization where we can try and improve our performance from each other. We implemented this by in-person teaching, by obviously information by email. For a while, there was a pocket card with all of the factors on it that people had in one of their pockets. We shared the information on a team meeting, and there were a number of us, or still are, who are ABC Pro champions who ensure that the documentation is correctly completed for each patient, and also that it's performed on every handover ward round. We have in the documentation on the PDMS, the Patient Data Management System, we have not only this all documented, what the risks are and what the options are, but also a color code per patient. So you'll open it and see the patient is coded red, which provides also an information for the doctors and the nurses. It's immediately clear. And the charge nurse of the unit has their patient list printed out with the appropriate color for the patient. So one of the major advantages is the entire nursing team immediately knows which patients we consider high risk. And my impression is that's made a huge change to how we speak, how we have a combined language about the severity of each patient.
This is absolutely wonderful. I'm sitting here thinking, we use Formula One for handovers from the operating room to the ICU. We use iPass for handovers from the ICU to the floor. We use a CHOOSE system, a PEWS, but we call it CHOOSE, Children's Hospital Early Warning System, red, green, yellow. And you've combined all three elements into one tool, which I think is wonderful. And I also like the fact that you're looking forward and you're time limiting. What are we going to do? Because in my experience, so often what we do is we say, we're going to do this, we're going to implement this therapy. But we often, at least in my experience, don't put a time limit, by when are we going to implement this? And so this is just wonderful. But of course, that leads to the question of how did you study this? What was your methodology? Because this is very complex environment to methodically tease out and measure. How did you do that?
So we first implemented this tool, and after we'd observed it for 2 years, we were fairly convinced that we'd seen a significant improvement in our cardiac arrest rate and also the performance of the team as a result of this. And consequently, we applied for an ethics approval to retrospectively perform a review of this single center pre versus post implementation study of the ABC Pro handover tool. We had 13 months of 6 months of implementation, where we performed the implementation and the teaching, where the team wasn't yet fully aware of how it worked, and then a 14-month post-implementation period. Our primary outcome, we decided we would focus on clinically relevant outcomes. So that was for us cardiac arrest and mortality. So our primary outcome was cardiac arrest per 1,000 PICU days. We defined a cardiac arrest, because this is obviously also another point, as more than 1 minute of mechanical resuscitation or cardiac defibrillation. And we defined a separate event as an event more than 60 minutes apart in the same patient. As secondary outcomes, we chose ECMO after a cardiac arrest, all types of ECMO, but also ECPR, defined as within 20 minutes of ROSC or during resuscitation, new neurological complications, and renal replacement therapy after cardiac arrest. We calculated the cardiac arrest rate per 1,000 PICU days for each of the study periods, both unadjusted, so the rate ratio comparing pre versus post implementation using a Poisson regression, so an unadjusted model and then an adjusted model and adjusting for sex, age, and the PIM2 severity assessment score or predicted mortality score. And we chose those 3 parameters because they've been previously shown to be associated with cardiac arrest in the literature. We then stratified the patients as to whether they were a cardiac patient, a patient coming to the ICU predominantly with a cardiac problem, or a cardiac surgical patient, because these 2 groups have been shown to have higher risks of cardiac arrest and also to benefit most from cardiac arrest prevention protocols as have been implemented very successfully in many centers.
So what were your salient findings from this study?
So I guess what this single center study shows is that cardiac arrests are a problem units. They primarily affect cardiac patients, but it can happen in all patients, and that interventions can actually substantially reduce this. Different types of analysis approaches, sensitivity analysis, and consistent for the subgroups. the effect was strongest actually for the cardiac surgical patients, right? And so overall, with a baseline rate of cardiac arrest that was comparable or lower than what has been reported in the literature, this intervention actually seemed to be associated actually with a very substantial cardiac arrest reduction, right? Now, what does this mean for patients? Cardiac arrests dramatically increase not only the risk of mortality, but they increase the risk of brain lesions, of prolonged ICU stay, and potentially actually of worse long-term outcomes, right? So a reduction in cardiac arrests is a very, very patient-centered outcomes and an important metrics for the quality of our ICU care delivered.
So to follow up on Luregn's comments, our main findings were we examined nearly 4,400 PICU admissions from nearly 3,000 patients. And these patients had a median age of 1.4 years. Just over a quarter were cardiac patients, 15% cardiac surgical patients. We found 63 cardiac arrests, 4 patients had recurrent arrests, and 2/3 of those were in cardiac patients, of which 85% cardiac arrests were in cardiac surgical patients, of those in cardiac patients. When we studied those cardiac arrests, we found an unadjusted cardiac arrest rate, which decreased pre to post implementation from 3.3 per thousand PICU days to 1.3 per thousand PICU days, with a risk ratio of 0.39. When we adjusted that, we found an adjusted risk ratio of 0.42, and that was similar between cardiac and non-cardiac patients. The adjusted risk ratio decreased most for the cardiac surgery patients, where the adjusted risk ratio was 0.32. We also found a reduced mortality in the post compared to the period. Pre-implementation, we had a 3% PICU mortality, and post-implementation, a 2% PICU mortality. We found less ECMO after cardiac arrest and less ECPR. We failed to find an association with renal replacement therapy after cardiac arrest. If we were to compare these risks or risk ratios with what is published in the literature, there are a number of studies with excellent cardiac arrest reduction implementations. A study with predictive analytics display with a risk score from SPADA from last year, 2025, they showed a reduction from 3 to 2.4 per thousand patient days. Ferguson et al. Studied the benefit of a bolus of adrenaline, which was pre-ordered and prepared at the bedside for hypotension, and reduced their cardiac arrest rate from 17.2 to 7.6 cardiac arrests per thousand patient days. And Riley et al. Performed an excellent cardiac arrest reduction bundle for specific high-risk cardiac ICU patient groups, and they found a reduction in their cardiac arrest rate from 5.4 to 3 cardiac arrests per thousand patient days. So I think when you compare our results with the literature, it's consistent with the reduction that has been seen in other groups.
One of the things I appreciate about Dr. Tasker's choice in pediatric critical care medicine to highlight single center retrospective reviews is that it's easy for us to think that the only things we should be reading are multicenter RCTs. But that's not the real world, and that's not where new ideas emerge from. This is a really brilliant idea. Nonetheless, it is a single center retrospective pre and post study design. What would you say are the salient limitations that our listeners should be aware of?
As you just said, that type of study design has a number of inevitable inherent limitations that just warrant for some cautions when interpreting the findings, and in particular, which may affect generalizability of the findings. First of all, cardiac arrests are not a very frequent event, luckily. And this means, of course, that the number of events per population that are there for analysis, they limit the amount of subgroup analysis. Then, of course, this is inherently bound to risks of unmeasured confounders, because other things may have changed. There may be unmeasured effects of the intervention, of the ABC Pro intervention, that although it is a reasonably clear-cut intervention which was invented here and not used before, it may come actually together with other multifaceted interventions that are not measured. That could be practices, that could be the culture in the unit. And so, of course, we cannot show any causality. One way to corroborate these findings, of course, could be if we have data which would show relationship with the degree of adherence of the team to the intervention and effect. But we have not conducted, and this is certainly a limitation in hindsight, we have not conducted structured quantitative or qualitative nested implementation studies.
What are the lessons that our pediatric critical care community can draw from your findings? In particular, I'm sitting here thinking, is this a tool? Is this really only a tool for the resource endowed environment, or could this also be utilized in part or in whole in a more resource constrained environment?
So this is an excellent question. Thank you. So our findings corroborate the notion that cardiac arrest could be considered a preventable event in some circumstances, in particular for cardiac surgical patients. And while our results are most relevant for cardiac patients and our intervention seems to be most effective in those, the benefits appear to extend to the general pediatric ICU patients. And specifically to answer your question, I think this is the major potential benefit from our intervention. It is very simple. It takes very little time. It has no cost. It barely requires any IT infrastructure. And while there are many excellent cardiac arrest prevention bundles available worldwide, either high tech with machine learnings and displayed scores, or lower tech with a bundle that gets implemented, many of them are difficult to implement. They take a lot of time and personal resources, or they take a lot of IT infrastructure and are complex to implement in a team. Ours is very simple to implement, was well accepted by the team. As I said, it's very low cost and doesn't take much time in the day. So consequently, the team is very happy to perform it. We notice the juniors in particular are very much like it, and the nurses are also very satisfied with the extra information they have on the patient. So I think it's absolutely implementable in every ICU around the world.
Wonderful. Well, we've been discussing your manuscript in the February 2026 issue of Pediatric Critical Care Medicine, describing your handover tool, the Airway Breathing Circulation Plan Risk Options Handover Tool. And as I mentioned earlier, I think you've got really an innovative fusion of some of the benefits but limitations of both the Formula One handover tool, the IPASS tool, and the Choose scoring system. So, what are your next steps?
So at local level, first of all, actually, the people are convinced that the unit should keep this. And in fact, it's been taken up now by the entire hospital for handovers across the hospital. In the unit, we try and conduct further work to really enhance the use of the tool, not only for the risk assessment and anticipatory care, but really as well to stimulate the speak up of different team members, and to really stimulate as well a discussion at the bedside. So in some ways, we want to use this as well to drive culture change, in particular to empower nurses and residents at the bedside, which are the team members that spend most time with the patient, right? That's sort of, what's happening at local level. And as you just alluded to before, in principle, this is a reasonably simple intervention. This is a parsimonious, low-cost, tool. And we would be very, very interested actually to work with units around the world to see if they're interested to implement it. And that type of studies will actually be required to assess the sustainability and generalizability and the impact it may have in other settings. Of course, from a scientific point of view, the ideal way to study such would be, for example, a stepped wedge cluster randomized trial. And very often when we talk about trials, we talk about medications, for example, or things that cost, things that change practice quite a bit. But this could be a reasonably simple intervention, an education, multi-professional intervention to test, to look at its implementation and to assess the impact on cardiac arrest across a variety of settings. So we hope that the work done here actually potentially can spur more interest in tackling something complex like a cardiac arrest by something reasonably simple, the ABC Pro tool, which can be owned actually by every team member in the ICU. And if that can create benefit for the patients and families, then of course that journey was worth the effort.
Well, this has been wonderful speaking with you both today. But one last question. Can you share with us what book you've read recently that really moved you?
Well, it was actually by John Irvin, the novel on the last chairlift. And he touched the string because my mother grew up in the Swiss mountains, not in Aspen, but in the Swiss mountains, and so that's chairlifts and snow, and it's part of childhood memories. And it was sort of tied with this history of what's been happening in the last 50 years. So I thought it was a great novel.
Very good. Jan?
So I'm afraid I have a quite different type of book. The book that's most helped me that I've read recently is Crucial Conversations: Tools for Talking When the Stakes Are High. Because as we know, our environment is not always without conflict, without difficult discussions, and it really helps me to have a positive outcome for the conversations that I have when things really are important.
Absolutely wonderful. Well, Dr. Janet Kelly-Geyer and Dr. Luregn Schlapbach, it's been a privilege speaking with you on Open Pediatrics today, and thank you very much for joining us from Zurich.
Thank you so much.
Thank you very much for the opportunity to speak to you today.
This has been a production of Open Pediatrics. You can find the resources and journal articles referenced in this podcast in the description. We have more podcasts like this one available everywhere you get your podcasts. Visit openpediatrics.org for more information.